Today we will discuss how to manage connective tissue diseases associated interstitial lung disease. I am Dr. Neeraj. This requires a change from the traditional pulmonology only mindset to a multidisciplinary integrated approach. So the first focus would be on identifying the inflammatory driver behind the interstitial lung disease. Then assess the pace of fibrosis and then balance systemic immunosuppression with lung-specific therapies. The diagnostic framework would be a multidisciplinary discussion. It's the gold standard. First, do a clinical and serological test to identify the triggering factor or the parent connective tissue disorder. It may be scleroderma, rheumatoid arthritis, myositis, Sjogren, or MCTD, or even myositis. Note that the ILD can be sentinel presentation in CTD. They needn't have the clinical features of the respective connective tissue disorder. Next is the radiological. Do an HRCT to distinguish patterns. NSIP or non-specific interstitial pneumonia is the most common CTDs associated with systemic sclerosis and myositis. It is characterized by ground glass opacities with subpleural sparing. The second common pattern is usual interstitial pneumonia, which is common in rheumatoid arthritis associated ILD. It is characterized by honeycombing and traction bronchiectasis. The third and uncommon is the organizing pneumonia pattern, which suggests an acute or a subacute inflammatory flare, more common in myositis. The second thing is to assess the pulmonary function. Focus on forced vital capacity and diffusion capacity for carbon monoxide. A decline in DLCO often precedes a drop in FVC. Next is to risk stratification, whether we should treat this patient or wait and watch. Not all ILDs require immediate extensive immunosuppression. The management strategy depends on 1. The extent of the disease. Anybody having more than 20% lung involvement on HRCT is a high-risk extensive disease and progressive disease, and they need treatment. Symptoms: when progressive dyspnea or cough is present, patients need treatment. And look at the physiological trend. A decline in FVC of 10% or DLC of 15% or greater over a period of 6 to 12 months defines progressive disease and progressive pulmonary fibrosis. And when you decide on treatment, think of the pharmacological options available. We usually follow a 2-hit strategy. The first hit would be the anti-inflammatory hit, which is immunosuppression. This targets the underlying autoimmune process. Mycophenolate mofetil currently is the first-line workhorse for most CTD-ILD, especially scleroderma, due to its favorable side effect profile compared to traditional cyclophosphamide. Cyclophosphamide is reserved for induction in severe, rapidly progressive interstitial lung disease, especially myositis-associated ILD or severe systemic sclerosis-associated ILD. Rituximab has been increasingly used in RA-ILD and anti-synthetase syndrome. Corticosteroids are vital for organized pneumonia patterns or myositis, but used with extreme caution in scleroderma due to the risk of scleroderma renal crisis, especially when the doses are above 15 mg. Second one is the antifibrotic hit, targeting the downstream fibrotic pathway regardless of the inflammation. Nintedanib, this is an FDA approved for systemic sclerosis ILD and progressive fibrosing ILDs. It slows the rate of FVC decline but does not typically improve the symptoms or the quality of life. Now we often use a combination therapy. That's the current trend. Example, mycophenolate with nintedanib aims to halt both the driver and the result of the injury. When it comes to beyond pharmacotherapy, you should always aim improvement in lung function and prevent deterioration of lung function due to flares of infection. So always these patients require the immunization, adult immunizations, especially the seasonal influenza vaccines, and also they may need a pneumococcal vaccine. As per the recommendations, guidelines of that country, you should give these patients these vaccinations. Also important are the non-pharmacological and sandwich therapies. GERD is often complicated by microaspirations of gastric acid that can exacerbate the fibrosis. So you need an aggressive anti-reflux treatment. Don't forget pulmonary rehabilitation, which is vital for improving functional capacity. And when the patient deteriorates or result in type 2 respiratory failure, think of lung transplantation. Reference should be made early for patients with DLC of less than 35% or those failing 2 lines of therapy.